is sorry again. So what is in the guidelines is in red is the E to A ratio, the EE prime ratio, the left atrial volume, and the tricuspid regurgitation continuous wave velocity. So let's go directly to the guidelines. These are the 2016 guidelines, so they are 7 years old. They have not been updated since then. And there are two parts of the guideline. There's part one, which is algorithm one, allows one to assess LV diastolic function without talking about pressures. And this is in patients with normal ejection fraction. In patients who have abnormal ejection fraction or reduced ejection fraction, or patients who have myocardial disease with normal ejection fraction, we should start with algorithm 2. But as you can see, it looks really dry and it's really difficult really to decipher. I'm just gonna show you things a little bit more in color. And let's focus initially on assessing diastolic function in patients with normal ejection fraction. There are 4 parameters to look at, and I'm gonna detail them for you later. We look for average EE prime, average E prime meaning the E over the average of the septal and lateral E prime. Anything more than 14, remember this number is abnormal. We look for the septal E prime velocity. Less than 7 centimeters per second is abnormal. Lateral E prime velocity less than 10 centimeters per second is abnormal. We look at the tricuspid regurgitation velocity. Anything more than 2.8 meters per second is abnormal. And we look for left atrial enlargement. Anything more than 34 ml per square meter, which is, this is LA volume index. Anything more than 34 is abnormal. Now, if 3 of these parameters are normal, then diastolic function is normal. If 3 of these parameters or more are abnormal, we have diastolic dysfunction. If 2 of them are abnormal or 2 are normal, then the diastolic function is indeterminate. Now, as I mentioned earlier, there is no need to always start with this algorithm. This is assessment of diastolic function in normal ejection fraction. And this is a bit confusing. So in patients who have known heart disease or suspected to have diastolic dysfunction, for example, they have reduced ejection fraction, LVH, coronary artery disease, and so on, we start directly with algorithm 2. And I'm gonna take you to algorithm 2 here. I drew for you the picture here on the left side to show you what we should assess for the algorithm. First of all, we should assess mitral valve, transmitral Doppler here, and you can see all this on the 4-chamber view. So we assess the mitral valve pulse wave, looking at the EA velocity. We assess the tissue Doppler imaging, septal and lateral mitral annulus. We assess the maximum LA volume, and we assess the tricuspid regurgitation continuous wave. So 4 parameters all assessed side by side from the 4-chamber view: mitral inflow velocity, tissue Doppler velocity, left atrial volume, and tricuspid regurgitation velocity. So, and once we get these numbers, we need to derive the E to A ratio on the mitral valve Doppler, so the E to A ratio, and then we need to derive the average E to the E prime ratio, okay? So these, either from the mitral Doppler, the E to A ratio, or from the mitral Doppler combined with the tissue Doppler for the EE prime ratio. And then I drew you here the picture of what one should look for. If your patient has a pattern looking like this, an impaired relaxation pattern, meaning the E to A ratio less or equal than 0.8, okay, and the E velocity, as you can see here, is less than 50 centimeters per second. Here is about 35 centimeters per second. So when you have a pattern like this with really a small E, less than 50 centimeters per second, the left atrial pressure is automatically normal. Now, if you have a restrictive filling like this, okay, and the E to A ratio is more or equal than 2, the LA pressure is automatically abnormal. Because we're talking here about patients who have myocardial disease or have reduced LV ejection fraction. So an impaired relaxation pattern with low E velocity less than 50 centimeters per second, LA pressure is normal. If you have a restrictive pattern with E to A more than 2, LA pressure is abnormal. So all these, the 2, 3, and 4, are for patients who are here in the intermediate state. When you have an impaired relaxation pattern with the E velocity more than 50 centimeters per second, or when you have E larger than the A, but less than 2 meters per second. Okay, so when you have a pattern looking like this or like this, then we have to go down looking at the other parameters here. We look at the EE prime ratio, we look at the left atrial volume, and we look at the peak tricuspid regurgitation velocity. Okay. So if 2 or more of these parameters is normal, meaning less than 2.8, less than 14, and less than 34, is 2 out of 3 are normal, therefore the LA pressure is normal. If 2 out of 3 of these these parameters are abnormal, then the LA pressure is abnormal. Okay. Now, what happens if we have 2 criteria? What do you mean we have 2 criteria? Typically, when we don't have a TR signal, when we don't have a tricuspid regurgitation signal, we have only the EE prime and we have the left atrial volume index. If both of these are normal, without knowing the TR signal, therefore the pressure is normal. If the EE prime and the LA volume index are abnormal, both of them, it means that the LA pressure is high. If one is abnormal, one is normal, it means we cannot determine the left atrial pressure. So the idea is we start by looking at the E to A ratio to define where we are. Are we here on the left side? Are we in the middle? Or are we on the right? If we're on the left side and the E is small, meaning the LA pressure is normal. If we have a restrictive pattern, meaning the LA pressure is high. And in between, we have to look at the 3 other parameters, the EE prime ratio, the TR velocity, and the LA volume to decide what's going on. Okay, what happens now if you cannot determine the LA pressure? If one of these parameters is positive, one is negative, then we have to look at other things. We have to look at other parameters like pulmonary vein Doppler, PR signal, mitral valve deceleration time, IVRT, Duval-Salva maneuver, look at the E over VP ratio, and maybe look further into strain of the left atrium and so on. I'll show you some of these examples later. Personally, I don't really stick only by the guidelines. I really look at everything else that the echo shows us, particularly these parameters here, the 4 or 5 parameters of the on the left-hand side, which are available on most of our patients. Now, there's a newly proposed algorithm by Dr. J.O. from Mayo Clinic, which really has only 1 algorithm, not 2. The parameters are pretty similar to what I showed you from the guideline. I mean, you can read it. I don't think it makes a huge difference. Now, quickly, I want to mention one thing is, as you can see, there's tremendous reliance on the EE prime ratio in the guidelines. And sometimes the EE prime ratio does not reflect LA pressure. When does the EE prime ratio not reflect LA pressure? It's typically a situation when the E prime here, the E prime does not reflect global LV relaxation. For example, in patients with normal hearts who have reduced preloads, for example, patients who are hypovolemic, the EE prime ratio does not reflect LA pressure. Or when you have mitral valve disorder, for example, significant mitral annular calcification, when you have significant mitral regurgitation, especially patients with normal ejection fraction, any degree of mitral stenosis, mitral valve repair or replacement. So major mitral valve disorders do not allow us to use the EE prime ratio. When you have infarction, for example, of the adjacent basal LV segment, for example, you can see here scarring of the basal half of the lateral wall. Here, you can see the E prime, the lateral E prime will be falsely low because of the scar here adjacent to the mitral annulus. So we cannot use this parameter. We cannot use the lateral E prime. Patient with constrictive pericarditis as well, we cannot use the EE prime ratio to reflect LA pressure. So let's start by showing you cases. This is the first case I want to show you. Patient here, there's a patient who's seen in clinic for preoperative assessment. Heart rate, as you can see, 78 beats per minute. Blood pressure, 112/68 millimeter of mercury. Patient has an S3 on cardiac auscultation. You can see here the 4-chamber view, the left ventricle, normal size, normal volume, normal ejection fraction. You can see the parasternal short axis view here as well. Ejection fraction is pretty normal. There are no wall motion abnormalities. However, what we see here, this is the mitral inflow pattern. You can see an E wave that is dominant A wave with 1.1 meter per second. You can see a small A wave as well. You can see the tissue Doppler here. I'm showing you the guidelines parameters, which are the septal and lateral tissue Doppler. The E prime is 12 centimeter per second, and the E prime here for the lateral is 20 centimeter per second. So the average E prime is 16 centimeter per second. The patient, there's no TR signal to see. So unfortunately, we cannot assess peak velocity. The left atrial volume index is normal at 26 milliliter per square meter. So the EE prime ratio in this patient is only 7, which is perfectly normal. So if we go to the question here, what do you think of the patient's diastolic function and left atrial pressure? Does this patient has normal diastolic function and normal LA pressure? Has grade 1 diastolic dysfunction and normal LA pressure? Grade 2 diastolic dysfunction with high LA pressure? Grade 3 diastolic dysfunction with high LA pressure? Or indeterminate? Well, the answer is simple here because this patient has normal diastolic function. Why the patient has normal diastolic function? The E prime velocities are perfectly normal. Okay, the left atrial volume is perfectly normal. And the EE prime ratio is perfectly normal. So there's absolutely no problem in this patient's LV relaxation. If you look as well at the pulmonary vein Doppler, you see a small s and a large D. And you see this typically in young patients who have perfectly normal diastolic function. The reason is as soon as the mitral valve opens, the blood is sucked from the left ventricle, from the left atrium into the left ventricle, because the left ventricle has perfect diastolic properties. And you can see this here pretty well on the lateral M mode. You can see when you do M mode from the 4-chamber view of the lateral annulus, you can see it takes quite a long time to contract. But look how fast this patient's myocardium is relaxing extremely fast. It's relaxing much, much faster than it takes to contract. So when you see this, you know that this patient has excellent myocardial diastolic function properties. And this is what we call filling by suction. This patient is 23-year-old male who has physiological S3, who has normal LV filling. And what do we mean by filling by suction? Is that as soon as the mitral valve opens here, you can see the LV, which has superb relaxation properties, like you saw here by M mode, okay, sucks the blood from the left atrium. So the blood is sucked quickly into the left ventricle at high velocity. So you have a large E wave. Not much blood is left for end diastole, so you end up having a small A wave. So this is what we call filling by suction. Okay, so this is a patient who has superb diastolic properties, even though the E to A ratio is quite high. But remember, this patient also has normal LV ejection fraction. Now, let's contrast this with case number 2, 75-year-old male. You can see here the heart rate, as blood pressure here is miswritten. Patient has NIHA class 3 dyspnea and as well an S3 on cardiac auscultation. Okay, but look at this heart. You can see hyperdynamic function. The LV is contracting very well. Let's look at again at the parameters of the guidelines. We look at the mitral inflow. You can see a large E and a small a. So the E velocity is 90 centimeters per second. You can see the E prime here is quite low. Remember, the lateral should be more than 10. The septal should be more than 7. Here, both are 4 centimeters per second. So very low E prime. There's major abnormal relaxation here. Okay. The E to E prime ratio is 23. And you can see here also the E to A ratio is very large. Looking further at additional parameters, as you can see here, the TR velocity is quite high. It's more than 2.8 meters per second. And if you look at the left atrial volume index, also the volume index is high. The left atrium is quite dilated. Okay, so let's look again at the pulmonary vein Doppler. Here, the left atrial pressure obviously is abnormally high. You can see a small systolic velocity and a large diastolic velocity. And this is typically what you see in older patients who have high filling pressure, so the S less than D in the pulmonary vein. Let's look at the M mode of the lateral annulus. You remember the young patient who has rapid relaxation? Look here, this is the contraction on M mode. The relaxation is very, very, very slow. You see, and this is atrial contraction here. So this patient has impaired relaxation, but you do not see it. Why? Because the LA pressure is high, and you can see the E velocity is quite high. And the impaired relaxation is shown here by the low E prime, giving you a high EE prime ratio, pulmonary hypertension, and enlargement of the left atrium. So you have all the parameters here to say that this patient has high filling pressure. So this is a patient. That's why we really need to know more about the patient. This is a 75-year-old patient who has a pathological S3. as compared to the previous patient who has a physiological S3. And the filling here is restrictive. Why? Here, as soon as the mitral valve open, the left ventricle is not sucking blood from the left atrium. The diastolic properties of the left ventricle here are poor. The LV is relaxing slowly. There's impaired relaxation. What's driving this high E is the high pressure in the left atrium, pushing the blood from the left atrium to the left ventricle. So here, we're filling by pushing rather than by suction. So if we compare the first patient and the second patient, the 23-year-old and 75-year-old, if you look at the mitral Doppler, you have a prominent E to A ratio in both patients. In the pulmonary vein Doppler, you have as well a small s and a large d in both patients. Okay. However, if we look further, the normal patient, the young patient, has superb relaxation properties. So you have a large E prime, has normal tricuspid regurgitation velocity, has superb relaxation by M mode, and normal left atrial volume. Okay. Here, on the right-hand side, in this patient, you have, who's 75-year-old with high LA pressure, you have abnormal relaxation. The E prime is low, the tricuspid regurgitation velocity is high, the left atrial volume is large, and you can see how poor the relaxation is on M mode. So things are different. The left atrial pressure is perfectly normal here. The LA pressure is high here, even though the mitral valve Doppler and the pulmonary valve Doppler look alike. But what's going to give us the diagnosis is going to be the E prime velocity, the tricuspid regurg velocity, the LA volume, the M mode, and other parameters as well. And what also would help us for sure very much is knowing the patient's age. This is a 23-year-old and this is a 75-year-old. So I hope that I mean, these two cases kind of enlighten you a little bit about reading the guidelines. So again, our young patient is here, has normal LV relaxation and normal LA pressure, and the older patient is here in grade 3, who has impaired relaxation. As you can see, the E prime is low, but we don't see it on the mitral inflow Doppler because the pressure is high. So the patient has impaired LV relaxation and very high left atrial pressure. Okay, let's show you a third patient. This is a 66-year-old patient, diabetes with hypertension, has prostate CA, received chemotherapy and radiation therapy. As you can see here, left ventricular ejection fraction is normal. I'm not saying systolic function is normal. Why I'm not saying systolic function? Because systolic function does not equate ejection fraction. They're not the same. You can have a normal ejection fraction, but if your patient with normal ejection fraction has abnormal strain or has abnormal S prime or abnormal MAPC, that patient would have a normal ejection fraction, but abnormal systolic function. So remember, ejection fraction does not imply systolic function. There are other parameters to assess systolic function, including strain, including GLS, including MAPC, and including S prime velocity. So this patient has normal ejection fraction. Let's look at the mitral inflow. You can see here the E velocity, the E to A ratio is 1.2. So we're going to be in the middle part of the guidelines. The TR velocity, I put it in green because it's normal, is 2.5 meters per second. This is the septal and the lateral tissue Doppler. The E prime is 6 in the septal and 8 in the lateral. So both are low. That's why I put them in red. And the left atrial volume index is 47 ml per square meter, which is large. So it's abnormal. Okay. So let's look further into this. Let's look about the first algorithm, assessment of diastolic function. This patient's average E prime ratio is not 14. The average E prime ratio is lower, so it's in green. The septal E prime velocity and lateral E prime velocity, both of them are abnormal, they're in red. The TR velocity is less than 2.8, so it's in green, and the LA volume index is large. So here we have 2 positive and 2 negative parameters for assessment of diastolic function. Therefore, it's indeterminate. We really cannot tell what the diastolic function is. So let's go to the guidelines and look. So we're here, as I told you, in the middle here because of the E to A ratio. And then we have only two of our 3 parameters here are normal. The TR velocity is normal and the E prime ratio is normal. So the left atrial pressure, according to the guidelines, is normal. I believe you would agree with me that 2 of our 3 parameters are normal. Therefore, the LA pressure is normal according to the guidelines. However, let's look further. I mean, is left atrial pressure truly normal? First of all, this patient has an L wave, which is kind of a mid-diastolic wave due to impairment in relaxation, which implies typically elevated left atrial pressure, even though the L wave is not very, very high, but it's quite prominent wave. It's beyond 0.3 meter per second. The deceleration time as well is quite short for someone at his age, is 190 milliseconds. If you look at the pulmonary vein Doppler, you see the systolic velocity is lower than the diastolic velocity, which is abnormal for someone who's 66 years of age. Okay. As I mentioned earlier, the patient has featured impaired relaxation, which we don't see on the mitral inflow Doppler. And if you look at the inferior vena cava, you can see the IVC does not collapse with respiration, implying that the pulmonary artery pressure is higher, even though the TR velocity is 2.5 meters per second. If you give PA pressure 10 to 20 millimeter, if you give right atrial pressure 10 to 20 millimeter of mercury, because the IVC is non-collapsible, therefore we end up having a high pulmonary artery pressure. So if you combine the L wave, you combine the deceleration time, you combine the pulmonary vein pulmonary vein Doppler S less than D, you combine the high RA pressure, the high PA pressure, and the impaired relaxation pattern, this patient's left atrial pressure is very likely elevated, even though the guidelines told us it's normal. Okay, so I'm showing you this case from our lab because one has to know that there are limitations to the guidelines. Okay, what are the limitations to the guidelines? Let's just go back a little bit, talk about the guidelines. The guidelines are confusing. The reason is we have, as you saw, there are 2 algorithms, one to assess LV diastolic function, and the other one is to assess filling pressure and to assess the degree of diastolic dysfunction. The guidelines have high specificity for assessment of filling pressures. They're not 100%, but the problem is the sensitivity is quite low. It's anywhere between 34 to 60% for detecting diastolic dysfunction. The problem as well is the tricuspid regurgitation velocity featured there as an important parameter. It cannot be assessed in up to half of the patients. We really cannot obtain a good TR signal in about half the patient. This leaves us with a high pool of indeterminate patient. As I showed you initially, you cannot determine this patient diastolic function. And the second algorithm told us the pressure, the LA pressure is normal. So there's a high pool of indeterminate patients, particularly in those who have early stage or mild diastolic dysfunction. Again, we don't take into account the right atrial pressure. As you saw in our case, I just presented to you, pulmonary artery pressure can be underestimated in patients who have normal TR velocity and high RA pressure. Additionally, all parameters, EE prime, LA volume, and TR velocity carry the same weight. Obviously, it cannot be the case. I mean, we cannot really say that the EE prime ratio is as important as LA volume, as important as TR velocity. Some of these parameters should carry more weight than others. For example, the EE prime ratio should carry certainly more weight than the TR velocity, which we don't get half the time, and the LA volume, which we can easily underestimate. Because the EE prime ratio can measure much, much more accurately, and it reflects better LA pressure as compared to LA volume and TR velocity. So we cannot give the same weight to all the 3 parameters that the guidelines gives. And one needs often to rely on additional parameters, which I just showed you. We need to look at the pulmonary vein Doppler. We need to look at other parameters I'll show you later. And one to really need to know about the patient. Clinically, we need to know the patient's age. We need to know about diabetes, high blood pressure, coronary artery disease, and other parameters. And what's important as well is the guidelines assume that patients with hypertension, diabetes, and coronary artery disease, all of them have abnormal diastolic function. It's not true. In fact, we have many young individuals who are, in their 30s, 40s, who have hypertension and or diabetes and or coronary artery disease, who have normal diastolic function because they're young, even though they have these diseases. So there's so many limitations to these guidelines that, these guidelines needs to be updated. They're good. You need to know them for your exam, but certainly they have major limitations. Let's start with case 4 now. This is a 55-year-old female who has history of hypertension, normal LV ejection fraction, and no mitral valve disease. And at 55, you can see the transmitral Doppler, the E to A ratio here, the E is smaller than the A. The E to A ratio is 0.8. And you can look at the E prime velocity here. The E prime is 12 centimeters per second. Here is 8. So the average is 10 centimeters per second. The E prime ratio is 6. So we have normal E prime here. So the relaxation appears to be reasonably good, and your EE prime ratio is normal. The left atrial volume index here is as well normal. And you can see, as I told you, the ejection fraction is normal. So is the strain, the GLS is as well normal at minus 21.6%. However, one of the parameters we look at in the guidelines is the TR velocity. The TR velocity is here 3.5 meters per second. So despite a normal E prime velocity, despite a normal E to E prime ratio, despite a normal LA volume, the TR velocity is high. Okay, and again, you see everything is green, the TR velocity is in red. This patient has normal left atrial pressure, obviously. However, what this patient has pulmonary hypertension. And the pulmonary hypertension, obviously here, is not of cardiac origin. You can be sure that the pulmonary hypertension is not due to any elevation in left ventricular filling pressure. So it's really important to keep in mind how to be able to separate pulmonary hypertension due to diastolic dysfunction and elevation in LV filling pressure from pulmonary hypertension due to pulmonary disease. Now, there are some useful echo patterns that you can look at the echo pattern, and you don't have to look at the algorithm to assess LV filling pressure. So this is a shortcut to bypass the algorithm. You just look at the echo parameter. You can say LA pressure is normal, LA pressure is high. Okay, let's start with this. Brahim, can you still hear me?
Yes, Doctor.
Okay, should we go maybe 10, 15 more minutes and then give people a little bit of a break?
Okay.
Okay, yeah. So you see, in a patient, let's say 64-year-old male with normal ejection fraction, in a patient older than 50 or 55 years of age, the systolic velocity should not be lower than the diastolic velocity. You can see in this patient, who's an older patient, the systolic velocity is smaller than the diastolic velocity. Automatically here, the LA pressure and the LV filling pressure is high. Okay, this is really an important parameter to have. Unfortunately, it doesn't work in many patients with normal LV ejection fraction. You see, it works more often in older patients who have reduced ejection fraction. I don't want to go too much into the physiological detail here, but in an older patient, whenever you see the pulmonary vein Doppler S smaller than the D wave, you can tell that the LA pressure is high. The only exception, and there's only one exception, older patients who had heart transplantation. For example, a patient who was transplanted at age 60 who had this. This can be normal because obviously the patient is 60-year-old, but the heart is only maybe 20 or 30-year-old. So the only exception to this is older patient with heart transplantation. Otherwise, whenever you see this pattern S less than D in the pulmonary vein patient, in an older patient, the LA and LV filling pressures are high. And this is here on the left-hand side. This is from a paper I wrote a couple of years ago in Journal American Society of Echo about pulmonary vein Doppler. Just to show you one thing here, that the diastolic wave in the pulmonary vein corresponds to the E wave on the mitral valve. So both are diastolic wave and both are early diastolic wave. So whatever happened with the E wave will happen with the D wave. So whenever you have here a large D wave, implies the patient has a large E wave across the mitral valve, okay? And this is why this patient will have a high left atrial pressure. So again, if you remember, the two patients presented you in case 1 and case 2, the young patient who have 23-year-old who have the small s and a large D wave, has a large E wave across the mitral valve because the LV is being filled by suction. Here, the 80-year-old who have a small S wave and a large D wave as well. And the D wave here as well, again, implying a large E wave, but the large E wave here is because of the high LA pressure. So the LV is being filled by pushing, and you just need to remember to see this difference. So a young patient, the pulmonary vein Doppler would look like this. In an older patient, meaning the LA pressure is normal. In an older patient, the same pattern in the pulmonary vein will tell you that the LA pressure is high. So now, another pattern in the pulmonary vein important is the looking at the A wave reversal in the pulmonary vein. If you line up the ECG in patient, line up the mitral valve and the pulmonary vein, If the A wave in the pulmonary vein is quite large, you can see the velocity here is quite high, almost more than 0.5 meter per second, and lasts well beyond the A wave across the mitral valve. You see the A wave ends here on the first line. The A wave across the pulmonary vein ends much later and is quite prominent. So whenever you see this, you know that the LV and diastolic pressure is high. Now, we don't line this up when we read echoes. What I usually do, I measure from the tip of the R wave to the end of the A wave. For example, let's say it measures, let's say 10 milliseconds. And then I measure from the R wave to the end of the A wave here in the pulmonary vein. Let's say it's 60 milliseconds. So the delay from the mitral A to the pulmonary A wave is 50 milliseconds. That tells us certainly that the LV and diastolic pressure is high. So this is another finding in the pulmonary vein beyond the S to D ratio is looking at the A wave reversal. Another important parameter to look at across the mitral valve, which I showed you a little bit earlier, is the L wave, which is a mid-diastolic wave that we see and which is due to impairment in LV relaxation. Whenever you see it, particularly when it's prominent like this, you see here is 0.5 meter per second. You can tell that the left atrial pressure is high and the LV filling pressure is high. And you can see it here as well in the tissue Doppler. You can see an L prime wave between the E prime and the A prime. So whenever you see this, you can tell that the left atrial pressure is high. Now, also very important is the Valsalva maneuver. Valsalva maneuver has really important diagnostic value in assessing filling pressure. Look at this patient, for example. The E velocity is 1.2 meter per second. The A velocity is 0.7 meter per second. The E to A ratio is 1.7 to 1. You can see with Valsalva what happened. The E velocity drops significantly, and the A velocity increases slightly, not much. So the E velocity drops from 1.2 to 0.4, whereas the A velocity goes up a little bit from 0.7 to 0.8. Look at the ratio. Whenever this E to A ratio decreases by more than 50% with Valsalva, this is highly specific for high filling pressures. You can see here the ratio went from 1.7 to 0.5. This is more than 50% decrease in the ratio. So as soon as you see such a decrease in the ratio of the E over A during Valsalva maneuver, you know that the left atrial pressure is high. Okay, look at this patient, for example, who's 55-year-old with ischemic cardiomyopathy. You can see this is the E and A. You can tell filling here is restrictive. The E velocity is high. Deceleration time is rapid. There's maybe a bit of an L wave here, which is not that prominent. And you can see a small A wave, small duration and small A wave velocity, restrictive filling pattern, E to A more than 2. With Valsalva, the L wave become prominent, but the E velocity remains high and the A velocity remains low, remains small. So obviously you can tell this patient has high filling pressure, but is not reversible. As contrast to this patient, to the previous patient, who has a reversible increase in the left atrial pressure. Now, what one can do, which I did myself on this patient, and during the Valsalva maneuver, and before as well, I looked at the pulmonary vein Doppler. You can see in this patient, looking like a pseudo-normal pattern, you can see a small S and a larger D, indicative of high left atrial pressure, which goes with what you're seeing E to A ratio here. With Valsalva, you see how the first patient, how reverse, you end up having an impaired relaxation pattern. So you go from a pseudo-normal to impaired relaxation pattern with a small E, large A. But look what happened also in the pulmonary vein Doppler. The S now becomes larger than the D. So you can tell reversal not only across the mitral inflow, but in the pulmonary vein. I mean, this has never been published before, but just to show you that you really can assess as well pulmonary vein during Valsalva maneuver. What's really as well important is that reversibility carries a substantially better prognosis than lack of reversibility. You can see here, if you have a restrictive pattern and looking at survival, you can see this is the reversible restrictive pattern. This is the irreversible restrictive pattern. Significant difference in outcome. Patients who have reversible pattern like this patient do much better than those who have irreversible pattern. They do much better survival-wise. They have a much, much better prognosis. So we don't do Valsalva in the echo lab only for diagnosis to tell whether left atrial pressure is high or not. We do it as well for prognosis. And Once we do it and the left atrial pressure goes down, you should know that if you optimize medical therapy, you can improve the patient filling pressure, and you can reverse this restrictive pattern. Okay, so really important as well, not only for diagnosis and for prognosis, but also for management, knowing that these patients, if you optimize their therapy, they will likely respond to treatment by improving their filling pressure. Again, another patient here, 69-year-old with diabetes, hypertension, and coronary artery disease. Again, if you line up the mitral and the pulmonary vein Doppler, you can see here on the mitral, you have what looks like a restrictive filling pattern. In the pulmonary vein, you have a large A that ends well beyond the end of the A wave. In the mitral valve, you know that the LV and diastolic pressure is high here. Okay, look at the tricuspid regurgitation velocity is 3 meters per second. Okay, with Valsalva, this patient reverses. You go from a restrictive pattern into an impaired relaxation pattern. The E velocity goes down, the A velocity goes up. Not only it goes up in velocity, as well the duration goes up. So the left atrial stroke volume goes up, and the E to A ratio goes down from 2.3 to 0.7, more than 50% decrease in the E to A ratio. So there is reversibility here. But also what you can look at the TR velocity, look at the pulmonary artery pressure decreasing in this patient. The TR velocity goes down from 3 meters per second to 2.2 meters per second. So not LA pressure came down and brought with it as well the pulmonary artery pressure. I mean, this also has never been published before, but I'm just trying to show you what you can do in the echo lab, not look only with Valsalva at the mitral Doppler. You can look at the pulmonary vein Doppler. You can look as well at the tricuspid regurgitation velocity and pulmonary artery pressure. Now, another important pattern to look for in the echo lab is what we call the B bump on the M mode. You can see here M mode across the mitral valve in diastole. This is the E and the A, and you can see here the B following the A. You can see this bump here in end diastole. We call it the B bump. Whenever you see it, it's highly suggestive of elevated LV and diastolic pressure. When you see this, before you look at the mitral Doppler, before you look at the LA pressure, before you look at the E to A ratio, at the EE prime ratio and the E prime velocities, you know that LV and diastolic pressure is high. Okay, another pattern that is very, very important, taking advantage of patient who has a patient who has a patent foramen ovale from the subcostal window. You have two patients here, patient A and patient B. Patient has, you can see, PFO with flow going from the left atrium to the right atrium. You should try to get linear with this flow. And if you do, this is the pulse wave Doppler across the patent foramen ovale. You can see a peak mean gradient of 3 and 1 millimeter of mercury. So the difference, LA minus RA pressure, the peak gradient is only 3 and the mean gradient is only 1. Then you look at the IVC. You see the IVC here is normal size collapsible, so the RA pressure is normal. So if the RA pressure is normal here and the gradient is quite low, you know that the LA pressure is normal, regardless. Okay, this is really very important. Contrast this with this patient, patient B, who has high velocity across the PFO. That's why we had to use continuous wave rather than, pulse wave. And you can see the velocity peaking here at 2 meters per second. So the gradient, peak and mean gradient are 16 and 8 millimeter of mercury. Look at the RA pressure also is high. So certainly this patient has a high left atrial pressure. So take advantage of the patient foramen ovale, try to line up with it and use it. I mean, this is not in the guidelines, okay? I wrote a paper a few years ago, or several years ago, about maybe now 9 years ago, about using patent foramen ovale as a window to the left heart hemodynamics. It can give you tremendous information. I mean, looking at this, for example, patient, you can see this is a systolic wave, this is a V wave, this is a reflection of a V wave in the left atrium. You can tell the patient has a large V wave in the left atrium. So, I mean, you're welcome to read the paper. It really gives you a lot of insight. So whenever you see a PFO, Doppler it and use it. Another something that is extremely important in my opinion, and I think this, to me, is more important than some of the parameters in the guideline, is to look for the pulmonary regurgitation signal. I don't want to dwell about this. I mean, I can talk to you for an hour about this, but the bottom line is, this is from personal experience. If your pulmonary regurgitation signal, whenever your patient has pulmonary regurgitation, Doppler it, and 80–90% of patients has a pulmonary regurgitation signal. I mean, have a trace PR. Most patients have trace PR. Doppler it. You can use either continuous wave or pulse wave Doppler. And whenever the end diastolic velocity here is 1.2 meter per second or less, and right atrial pressure is normal, you can rest assured that left atrial and PA pressure are normal. Why is that? Why is that? Because let's assume a patient has a PR, like, for example, this patient, the PR and diastolic velocity is about 1 meter per second. With inspiration, it goes even further lower. Whenever I see this, I say, okay, the IVC looks normal. Khalas, I really don't want to look at the guidelines anymore. I know LA pressure and PA pressure are normal. How do I know that? How do I know that? If your PR and diastolic velocity is 1 meter per second, therefore the gradient between the pulmonary artery and the RV in end diastole is 4 millimeter of mercury. So let's assume that the RV EDP is 5 to 10 millimeter of mercury. How we do it? By look at it, we look at through in the inferior vena cava and the hepatic vein. You see the IVC here collapses with inspiration. You don't have a major A reversal in the hepatic vein. You know the RV EDP is high. So let's not give it 0 to 5. Let's even give it 5 to 10. Let's be more generous and raise our pressure just to tell you that this thing works. Therefore, the PA and diastolic pressure is going to be 9 to 14 millimeter of mercury. And we know that the wedge pressure typically is 0 to 5 millimeter of mercury less than the PA and diastolic pressure. So your wedge pressure, and therefore the LA pressure, has to be less or equal than 14 millimeter of mercury. Therefore, it's got to be normal. So whenever you have the PR velocity and diastolic velocity of 1.2 meter per second, decreases with inspiration, and you have a normal IVC, you can rest assured that the left atrial pressure and the PA pressure are normal. It works very, very well. I mean, this is a parameter that I personally use. I think it works very well. It's highly reliable. Unfortunately, I mean, not really much in the guidelines, and it's not much talked about. Another thing important to look for is the motion of the intra-atrial septum. If you have a patient, for example, like this, you see the intra-atrial septum here moving back and forth from the LA to the RA, and you look at the IVC, and you know your RA pressure is normal. So the LA pressure has to be normal. Why? Because if the LA pressure is high, the septum is not going to be moving back and forth between the LA and the RA, and the movement here is due, obviously, to the effect of the difference in pressure between the LA and RA during filling. Has to do a lot with respiration, because with inspiration, you increase filling of the right atrium while you decrease filling to the left atrium. And in expiration, you decrease filling to the RA, whereas you increase filling to the LA. So when you have the septum, intra-atrial septum moving left and right, and the RA pressure is normal, I can tell you that the LA pressure will be normal. Okay. So these are all things important that the guideline doesn't even talk about. Now, I want to just spend maybe few minutes here, and then I'll give you a break about troubleshooting the guidelines, just to tell you how the guidelines can be inaccurate. Look at this patient, for example, looking at the left atrial volume, which is a major parameter in the guideline, as you remember. You can see here from the 4-chamber view, the left atrial area is 19 square centimeter, and from the 2-chamber view is 18 square centimeter, giving us a left atrial volume index of 32, which is normal. However, if you look at the subcostal window, the left atrium is very large. The left atrial volume index is, the left atrial area is 30 square centimeter, which for sure will give us a severely dilated left atrium. So we went from having a normal left atrium from the 4 and 2-chamber view to having severe left atrial enlargement. And this is obviously the view here in the subcostal window that the MRI, people in MRI, when they look at left atrial volume, this is the view they use here. Okay, so what's happening in this patient is that the left atrial is foreshortened in the left atrium, the 4-chamber and the 2-chamber view. Therefore, in the guideline, if you go through the guidelines, we're going to report left atrial volume index as being normal, whereas the left atrium is severely dilated. Okay, it's really important to know that the left atrium is dilated in the majority of patients with elevated LA pressure, but the left atrium can be dilated as well in patients with normal LA pressure. Patient could have elevated LA pressure that normalized, or they can, for example, have high flow state for numbers of reasons. So you see, this is a major shortcoming of the guidelines, is that we can easily underestimate LA pressure. What about the TR velocity? I mean, this is peristaltic RV inflow. You can see tricuspid regurgitation here. We're Dopplering it, and we say TR velocity is about 2.3 meters per second. Guess what? This is normal TR velocity for the guidelines, so we say normal TR velocity. But is this correct? No, it's incorrect, because look at the subcostal window. We're more linear with the TR, and here the TR velocity averaging 3.7 meters per second, which is abnormal now. So again, you know, if you spend more time trying to get a good TR signal, here, obviously, we don't see the peak of the TR, and people would look, say, oh, I think it's about 2.3 meters per second and normal. No, it's not. TR velocity is high, and therefore this patient has pulmonary hypertension. So instead of having a negative TR velocity in the guideline, now it's positive. Okay. Another thing here is, for example, look at the E to A ratio, looking at the E to A ratio, and then obviously here the sonographer overestimated the peak E velocity, as you can see. And is this really an A wave? No, it's not an A wave. This patient is in atrial fibrillation. There is no A wave. This is an L wave, in fact. So obviously one has really to pay attention, saying the patient has, E to A ratio. This is not the E to A ratio. The patient is in atrial fibrillation. A final thing really important to look for is when you see a funny looking mitral valve Doppler. You can see, a mitral valve Doppler looking like this. You see an E velocity, and then you can see forward flow, backward flow, forward flow, backward flow, forward flow, and so on. And you see, you can see it here again. And you look at the pulmonary vein Doppler, and you see a small systolic velocity and large diastolic velocity. This patient has high LA pressure. You can see the E velocity is high. You have different size A waves here. The deceleration time is rapid. Does this patient has high LA pressure? Well, be careful. This patient has atrial flutter. And whenever you have atrial flutter, you cannot use deceleration time, because the atrial relaxation during flutter will reduce your deceleration time and will give you even a higher E wave peak. And you can see the flutter waves giving you flutter waves on the transmitral Doppler. So it's really important to know the rhythm. Is the patient sinus rhythm, the patient in atrial fibrillation, or the patient in atrial flutter? So if you like, I will stop here to give you a break, and then I'll continue. I have a few more cases to show you, and would it be okay to take a 5-minute break now?
Yes, doctor. I think it's better to take 10-minute break, then we'll be back.
You want 10 minutes?
Yeah.
Okay.
Please.
So we'll reconvene at what?
2:30.
2:30. Okay. Thank you.
Thank you.
بها فاضل.
وخروا عن الباب الحين بسطة. وش ذا؟ بيت كبير قاعد يتطبل. بسم الله، يكون قاعد أهلوس. لا والله من جد قاعد يتطبل. يا شرطة، في شخص بنى بيته في نص الطريق المختصر اللي في حارتنا. كيف بنى بيته في نص الطريق؟ له وين قاعد؟
إبراهيم كان
زي ما
يميوت.
قلنا يا ضابط، وإذا مو مصدق تعال معنا.
دكتور بهاء.
Ibrahim, can you hear me?
Yes, Dr. Baha.
Okay, I'm having
Yeah, I think now we can start.
I'm having difficulty with Zoom.
Oh.
Okay, so let's start with case 5. So this is a 68-year-old male with history of permanent atrial fibrillation, diabetes, and hypertension. And as you can see here, this patient is in atrial fibrillation, however, has normal or supernormal even ejection fraction.
Dr. Baha, can you please put slideshow?
Oh, sorry. Okay, thank you. I don't know why I'm having trouble today with Zoom. Can you hear me, Ibrahim?
Yes, Dr. Baha.
Okay, somehow the Zoom share is just stuck. Okay, here we go. Can you see it now?
Yes, now clear.
Okay. Okay, so again, this patient has a very good ejection fraction. You can see here at the transmitral Doppler, you obviously can see E waves, but no A waves. And what typically happens in atrial fibrillation is that the E wave velocity tends to go up, and the deceleration time as well tends to go down. Even the filling pressure can be normal. So looking at this patient, you can see the E velocity is 105 centimeters per second on average. The lateral E prime, as you can see here, is quite healthy. On average, about 15 centimeters per second. Also a healthy septal E prime, which is 11 centimeters per second. And the E prime ratio is typically normal, perfect normal at 8. And you can see the TR velocity at 2.4 meters per second. So all in all, you really see good relaxation properties of the left ventricle, a reasonable, a normal EE prime ratio, a good TR velocity. Now, the left atrial volume here, we should not be used this criteria in patient with atrial fibrillation, because the grand majority of such patients will have a large left atrium. But if we look at the guidelines, this is the guidelines assessment of LV filling pressure in patients with atrial fibrillation. They tell us to do things that are really not easy to do and not practical. For example, looking at the peak acceleration rate of the mitral velocity, we can do it, but we often don't do it routinely in the lab. Look at the IVRT. Measuring the IVRT in sinus rhythm is quite difficult. How come measuring it in AFib, particularly when rapid? It's almost impossible. Looking at the deceleration time of the pulmonary vein being less than 220 milliseconds, if being less than 20, meaning the LA pressure is normal in AFib. I personally don't put much weight in it. I don't really believe the data. E over VP ratio is quite useful, but I think what's important looking at the EE prime ratio, and here they say septal more than or equal than 11. If that's the case, that implies that the LA pressure is high. I personally, what I do is I follow the guidelines. If the patient has normal sinus rhythm, and I look at parameters, but I look at the other parameters I showed you as well. I showed you so many other parameters that you can assess LA pressure with. And what's really important is to look at the patient. I mean, is there LVH or not? Is the ejection fraction normal or reduced? If it's reduced, looking at the IVC, if the patient has high RA pressure, typically they have as well high LA pressure. Looking at the deceleration time of the mitral of the E wave in patient with reduced EF also works very well in these patients. Patients who have high LA pressure in AFib, they tend not to have much variation in the peak E velocity from beat to beat. Looking at the PA pressure as well and the TR velocity as are important things, but clearly here all the diastolic parameters are normal and the PA pressure is normal. So this patient with atrial fibrillation has very likely normal filling pressures. This is case number 7, a 76-year-old male, diabetes and hypertension who has dyspnea on exertion, NIHA function class 3. As you can see, patients' vitals are normal. The pro-BNP here is not abnormal, as you can see, only 224. Patient had coronary angiography, which showed non-obstructive coronary artery disease. As you can see here, the LV ejection fraction is normal. You can see this, the strain, the GLS is reasonably okay at minus 18.1. Let's look at the mitral inflow. You can see E and A, what looks like an impaired relaxation pattern. The E to A ratio is 0.8. Deceleration time is 180 milliseconds here. The tissue Doppler septal and lateral E prime are low, so there's some impairment in the relaxation here. You see E prime of 6 here, E prime of 6 as well in the lateral. The EE prime ratio, 67/6, would give us an 11, which is normal. So even though the E prime are abnormally low, the ratio is normal. And then you look at the TR velocity is normal. It's 2.4 meters per second. Therefore, you say that very likely the PA pressure is going to be normal. Now, the abnormality here is the left atrial volume index is 43 ml per square meter. So what's in red is abnormal. Looking at the pulmonary vein Doppler, you can see systolic velocity and the D. And what's bothering me a little bit here is the D is quite sizable in someone who's 76-year-old. It should be much smaller than this. So the large D wave in the pulmonary vein is bothering me. However, if you go by the guidelines, let's look at the guidelines. The guidelines, obviously, when you have an E to A ratio here of 0.8 and the E velocity more than 0.5, we fall here in the middle. So we have to look at the three criteria. We have to look at the TR velocity, we have to look at the LA volume, and we have to look at the EE prime ratio. The EE prime ratio is normal. The TR velocity is normal. The only abnormality is the LA volume. So 2 out of 3 are normal. It tells us the LA pressure is normal. But guess what? I mean, this patient has dyspnea on exertion. Now, the patient is lying on his side in the echo lab with a normal LA pressure. How does normal LA pressure at rest tell me what happened with activity? So here the guidelines tells you something that is important. If the patient is symptomatic, consider coronary artery disease, which we already, patient had coronary angiogram, which showed non-obstructive disease, but also proceed to do a diastolic stress test. And I don't know if you have heard of diastolic stress test before, but I'll explain this to you a little bit. What is diastolic stress echocardiography and why to do it? What we need to know is that many patients who have heart failure with preserved ejection fraction, which this patient has, he has a normal ejection fraction, but he has dyspnea on exertion. And the question is this dyspnea due to heart failure, or is this dyspnea due to something else, to lung disease, for example? Many of patients who have heart failure and preserved ejection fraction, HFpEF, have only exertional symptoms. They have no symptoms at rest. They have a normal pro-BNP level, which our patient did, have normal LV filling pressure at rest, as our patient did, according to the guidelines. However, these patients have what we call impairment in LV diastolic reserve. What does that mean? That means the normal filling pressure at rest will increase with exertion. Let's look here on the right-hand side. This patient has heart failure preserved ejection fraction. You can see at rest, this is wedge pressure in blue and LV pressure in red. At rest, wedge pressure is normal. Look what happened with exercise. Obviously, the LV systolic pressure goes up because blood pressure goes up. But look what happened to wedge pressure. Wedge pressure substantially goes up with exercise. So this patient has heart failure, preserved ejection fraction, and dyspnea on exertion. Okay. And remember, the echo guidelines have low sensitivity to detect patients with HFpEF on the basis of the resting data alone. I told you we miss quite a bit of these patients. So this is when we should do a diastolic stress echo, because the diastolic stress echo detects the impaired LV diastolic reserve. And it helps us distinguish cardiac from non-cardiac related dyspnea. Who are the candidates for diastolic stress echo? This patient I just showed you, patients who have exertional symptoms and normal filling pressures at rest. And particularly patient whose resting echo does not explain the patient's symptom, which is mainly dyspnea on exertion. Okay, so let's look quickly at what does exercise do to the normal physiology. What does it do to patient with HFpEF? Effect of exercise, LV diastolic suction, which is part of the relaxation. In normal patient with exercise, it improves. So the LV suction will suction much better during exercise than normally. In patient with HFpEF, the suction does not improve with exercise. The myocardial relaxation, it will improve with exercise in patients who are normal. However, it stayed the same or increases just a little bit in patient with HFpEF. So the E prime in patient with HFpEF would stay the same with exercise or go up a bit. The E velocity go up in normal as well in HFpEF patient with exercise. The EE prime ratio would remain normal in patients who are normal, would remain normal with exercise in normal patients. Why? Because the E velocity goes up, the E prime velocity goes up because the relaxation improves. So the E prime goes up. The E velocity goes up because the preload increases with exercise. The E goes up, but the ratio remains normal. What happened in patients who have HFpEF with exercise? The E velocity goes up. The E prime stayed the same or goes up a bit. So EE prime ratio goes up with exercise. Okay. Now, the other concept important to know is there's something called the minimal LV diastolic pressure. Let's look at this patient, for example, at rest and with exercise. This patient is normal. This is the minimal LV diastolic pressure, which is at -1 millimeter of mercury. And this is the LV EDP. With exercise, the minimal LV diastolic pressure goes down. Why? Because you have better suction and better relaxation, while the LV EDP goes up. Okay, you can see it goes from LV EDP goes from 8 to 20 millimeter of mercury. This is normal as long as the minimal diastolic pressure goes down from -1 to -5 to offset the increase in LV EDP. So the mean diastolic pressure in the left ventricle doesn't change much, particularly because the minimal diastolic pressure goes down from -1 to -5 because you have better suction and better relaxation. In HFpEF patient, you see the minimal LV diastolic pressure is -1. The LVEDP is already high at 16, mildly elevated. What happened in HFpEF patient? The minimal LV diastolic pressure doesn't go down. In fact, it goes up. It went up to 16 here. And the LVEDP goes up from 16 to 30. So the minimal LV diastolic pressure goes down in normal patient, goes up in HFpEF patient. The stroke volume obviously goes up better in normal than in HFpEF patient. So normal patient has adequate diastolic reserve. They have the HFpEF patient have impaired diastolic reserve. So quickly again, let's look at normal abnormal response to exercise echo. This is patient A. You can see green is normal. With exercise, this is baseline 25, 50 watts, and 70 watts. So this is inclined bicycle exercise. The E velocity goes up with exercise. Okay, you see goes up here. And the E prime velocity increases as well with exercise. So you have what we call concordant increase in E velocity because of increased preload and E prime velocity because of improved relaxation. So the E prime ratio remains the same. So you have normal, the filling pressures don't go up with exercise. Let's look at patient with HFpEF, patient B. You see with the E velocity goes up with exercise as expected because you increase preload. Look at the E prime velocity. It stays the same or increases minimally. You see, so you have increase in E with minimal increase in E prime. So there's discordance between E and E prime. So the E prime ratio goes up and this patient have exercise-induced increase in filling pressure. So what are the parameters we look at in diastolic stress echo? We start with at rest, you need to have a septal E prime less than 8 and lateral E prime less than 10, kind of abnormal relaxation. The E prime ratio, if the E prime ratio remains less than 10 with exercise, meaning E and E prime goes up proportionately, that means that's normal response, that's normal. In patient with HFpEF and increased filling pressure with exercise, the E prime ratio goes above 14. Between 10 and 14, the E prime ratio is indeterminate. And the TR velocity the same, it's less than 2.8 with exercise in normal patient is more than 2.8 and typically usually more than 3 meters per second in patient with HFpEF. So let's look what happened to our patient. Our patient, we put him on the inclined bicycle and we did a diastolic stress echo. You see the heart rate went from 60 only to 94 beats per minute. The patient became dyspneic. So inclined bicycle, 50 watts only. You see the E velocity went from 67 to 125. The deceleration time went from 180, it shortened to 120, okay? And you can see what happened to the E to A ratio. Look what happened to the TR velocity. Went from 2.4 to 3.6. And the E prime ratio, the E prime was 6, here 6 at rest. It went up to 7 and 6. Didn't change much really with the exercise. So the E prime ratio went from 11 to 19, okay? So typically, what happened with this patient became dyspneic because the filling pressure went up. And if you look at the pulmonary vein Doppler with exercise, which we did, it's not really part of this test, but if you want to look further, you can see here the S was almost the same size, a bit bigger than the D. You can see the S is small and the large D because the patient has a large E wave here. So typically the S to D ratio of 1, it became 0.6. So this patient has increase in filling pressure with exercise. You can see the E went up, the E prime did not change, the TR velocity went up. So the E prime ratio 11 to 19, TR velocity 2.4 to 3.6. This patient is here. So there is increase in LV filling pressure with exercise. This patient's dyspnea is due to heart failure with preserved ejection fraction. Even though if you go by guidelines, you see the TR velocity is normal, the E prime ratio is normal. The guidelines told us that this patient's filling pressure is normal. But guess what? Yes, it is normal at rest, but as soon as the patient gets up and walks, gets short of breath, and you cannot really tell that by a resting echo. And this is what I wrote here. I wrote that the value of a resting echo for a patient with exertional dyspnea is probably similar to the value of a resting ECG for a patient with exertional angina pectoris. I mean, patient having angina pectoris and chest discomfort sounding like angina pectoris. What is the value of a resting ECG? It has some value, but not really much. You really need in patients who have exertional dyspnea, you really need to do a stress echo. And particularly diastolic stress echo, if you really cannot explain the display on exertion based on your resting echo, and many times you cannot. And as I mentioned earlier, many times your patient has normal ejection fraction, they have a normal pro-BNP and normal filling pressure at rest. The diastolic stress echo is the only way to get to the cause of your patient's symptoms. Now, let's move on. Case number 8 is a 70-year-old female, diabetes, hypertension, chronic kidney disease, tachycardia. Look at the mitral Doppler. You see the E and A velocity are almost the same. You see the heart rate here is 102. So she's tachycardic. E velocity 90 centimeter per second, A velocity 100 centimeter per second. So where does this put us? I mean, does this patient have impaired relaxation? Are we here? Are we this pseudo-normal pattern? Are we here in the restrictive pattern? Really, not really easy to tell. But what I really want you to know is that you see the height of the A wave is only 35 centimeters per second. The A wave starts here and ends here. So if you slow down the heart rate from 102 to 61 beats per minute, the A wave is going to be this tall. I mean, it's going to be this tall from here to here, which is here. So if you slow down the heart rate, the E velocity will remain the same at 90, but the A velocity, which is 100 centimeters per second here, is only 45 centimeters per second. Why? Because this is the height of the A wave. It starts here and it ends here. Okay, so your E to A ratio at 0.9, okay, now is a E to A ratio at 2.3. If you look at the tissue Doppler velocities, you have an E prime of 6 and E prime of 6. So you have pretty abnormal E to E prime ratio. So this patient as well, you can see LA volume index is high. This patient here is a restrictive pattern. So a 70-year-old patient who has a pattern looking like this, because you know that this should look like this. The A velocity is only 35 centimeters per second. You don't really have to slow down her heart rate. You would know just by looking at this, because what you're going to need to do, you're going to count the height of the A wave here, okay, of 35 centimeters per second. You know, it's going to look like this. You know, the E to A ratio is more than 2, and you know this is restrictive filling. So you know this patient has high LA pressure. So important really to pay attention to the heart rate. Okay, I'm going to skip this one. Let's go a little bit beyond the guidelines. Let's say 70-year-old male with ischemic cardiomyopathy. As you can tell here, patient has an ejection fraction of 21%. The GLS is minus 5.7%. Patient has low stroke volume. You can see the TVI is 10.8. And let's look here. You can see, obviously, the ejection fraction is severely reduced. But look at your patient. I mean, look at this patient. And this patient, heart rate is 96 beats per minute. But the E and A are totally fused. You know, they're fused. And you look at the septal and lateral tissue Doppler. Also, you have, you know, an E prime, A prime, they're fused together. So it's not an E or E prime or A prime, they're E prime together. They're fused at 9 centimeters per second. And here at 10 centimeters per second, but they're fused. So what can one do? I mean, can we divide EA over E prime, A prime? I don't suggest we do this. But look at the velocity here. It's average about 75 centimeters per second. This patient with severe impairment in LV systolic function. So most of the time, what we think here is this patient who has severe impairment in LV function is relatively tachycardic, and that very likely the filling pressures are high, and therefore probably best to treat with diuretics. If you look at the guidelines, what to do in patients with sinus tachycardia, it says you look at mitral inflow, and we have fusion of the E to A. You look at the IVRT during tachycardia. I mean, during normal heart rate is difficult. With tachycardia, it's very difficult. Pulmonary vein as well, not very useful, because pulmonary vein as well, you have fusion of the systolic and the diastolic velocity. Average E over E prime, we don't really have E anymore. We have EA together and E prime, A prime together. And they say here, wait for a premature beat, for a pause, and then after the premature beat, you have a pause, and you can look at the E ratio during the pause, but you can sit for an hour and patient not have a single PAC. So the guideline is not useful here. What should you do? Well, what we did on this patient is we did a carotid sinus massage to slow down his heart rate. And look what happened. I mean, heart rate of 96. We did the carotid sinus massage, and look what happened. We end up having an impaired relaxation pattern. The E velocity is very low, and you have a tall A velocity. And once we released, you see the heart rate came down with the massage, carotid sinus massage from 96 to 68 beats per minute. And once we release the carotid sinus massage, you can see after the release how the EA are fusing, and they went back and they fused together. So here, during the carotid sinus massage, you can see the peak E velocity is almost 0.2 meter per second. The E to A ratio is very low, 0.3. So if you look at the guideline, this tells us this patient has normal LV filling pressure. Let's look at the IVC. Very, very small and collapsible. I mean, the RA pressure is close to 0. So in this patient who has a dilated cardiomyopathy, ejection fraction of 23%, severely impaired, your first impression is that, oh, this patient is tachycardic with severe LV dysfunction. Let's diurese this patient. Obviously not. I think this patient is tachycardic for one reason, is that filling pressures are low on the left side as well on the right side. This patient probably is over-diuresed, and this patient is hypovolemic, and this patient does not need diuretics. To the opposite, we should stop the diuretics and we should give this patient fluid. And you see here, the carotid sinus massage helped us tremendously in this patient. Obviously, it's not in the guidelines for tachycardia, but it's tremendously helpful. Okay, another patient here, 53-year-old, dilated cardiomyopathy, ejection fraction 27%, GLS minus 7.3, and you can see again significant LV dysfunction. Okay, and again, I mean, heart rate, as you can see, is rapid in this patient, and you have fusion of the E and A. Okay, heart rate here is above 100, and the EA are fused. And again, you know, there's E prime in the septal. I don't see an A prime. In the lateral, you can see A prime and A prime. They're 8 and 10 centimeters per second. But here, this is fused. The E prime here is not too bad. But we did carotid sinus massage on this patient. And you can see with the massage, you see the heart rate slowing down. And then you start seeing an E and A, E and A. And then we release the massage, and then they start fusing again. So the heart rate went from 103 down to 86 beats per minute and went from this pattern to this pattern. This looks pseudo-normal, okay? The peak E velocity is 80, the E to A ratio is 2. So this patient has kind of restrictive filling, and the left atrial pressure is high, contrary to the first patient I showed you, whose LA pressure is normal. And we did hear something that I don't recommend that you do too often, but during the carotid massage, I asked the patient to Valsalva. And so here, so this is the baseline. You see the E to A ratio at baseline. The E and A are fused. The LA pressure is indeterminate. We did the carotid massage. We saw this, what looks like pseudonormal to restrictive filling, E to A ratio of 2. So the LA pressure is high. And during the massage, we asked the patient to Valsalva, and the patient went into, an impaired relaxation pattern with E to A ratio of 0.9. So we know that the LA pressure is reversible with Valsalva during the carotid massage. So we got tremendous information on this patient just by doing 2 maneuvers at the same time in the echo lab. So in this patient, obviously the filling pressure is high. So another patient here, 66-year-old with ischemic cardiomyopathy, also tachycardic, 101 beats per minute, and you can see the E and A are fused. Once we started doing the carotid sinus massage, you see this patient went into a pause, into a sinus pause of 3.2 seconds. And obviously we got frightened. This is the E and A, this is the E, and then we stopped. Obviously, this is the A, and restarted. So you have to be careful once you do carotid sinus massage. There's certain, you need to know the technique, how to perform it. You need to know the contraindication. I'm not going to go through them. But here it was helpful to massage for us. Why? Because patient went from this pattern into this impaired relaxation pattern. So if we knew that this patient has normal filling pressures, that's one. 2, we know that this patient has carotid sinus hypersensitivity. We made 2 diagnoses at the same time in this patient. But obviously, you really need to know more about this. We wrote a paper about performing carotid sinus massage many years ago, 10 years ago exactly, in the lab. I showed examples, and you can read it. But it's quite helpful in the lab. You need to know how to do it. You need to know which patient to do it on, which patient not to do it on. So it's really useful telling us what to do, kind of beyond the guidelines. Now, what I want to share with you as the last part of the talk is recognize the power of comparison in echo. And this power of comparison is tremendously important for your patient. You have to compare current studies to previous studies. And I'll show you an example of the power of comparison. 68-year-old male with history of myocardial infarction, ejection fraction 35%. You can see the patient has a large scar here in the LAD territory. Again, You can see here a large scar, and you can see septal scars, so large LAD territory infarction, significantly impaired LV function. And this is the patient transmitral Doppler. You can see what looks like a restrictive pattern. You know now, a tall E wave, small A wave in duration as well as in velocity. The E to A ratio is high, more than 2.0. Unfortunately, the sonographer did not perform a Valsalva maneuver. You can see the E prime velocity here is low. So you can see, so restrictive pattern, E to A ratio 2.5, E prime lateral 4, E prime septal 5, E prime ratio 22, so it's quite high. TR velocity is also high at 3.2 meters per second, and the pulmonary vein Dopplers have a small systolic, large diastolic. You see here, it's a restrictive pattern, high LA pressure. All the parameters go with high LA pressure. The restrictive pattern, the low tissue Doppler velocity is major abnormal relaxation, but you don't see it because the LA pressure is high. The E prime ratio is high. The TR velocity is high. The S to D ratio is abnormal. And the left atrial, I did not include here left atrial volume. And you can see here, the left atrial volume is quite large. I mean, this is a dilated left atrium. So we have all criteria to say that this patient has high LA pressure. This was in 2018. Now, the patient was seen in clinic, was treated, and then this is the echo 2021. The echo looked exactly the same. The wall motion abnormality the same. The ejection fraction was the same. There was no change. However, what changed is this. Look at the Doppler now. The patient now has an impaired relaxation pattern. You can see a smaller E than A velocity. Okay, the E velocity is only 50 centimeters per second. The E to A ratio is 0.7. Now, the E prime, septal and lateral did not change. They're still the same. So the impairment in relaxation has not changed. Okay. But look what happened to the EE prime ratio, 22 to 13, okay? You see 22 here, EE prime ratio. Here, 13, which is in the normal range. The TR velocity as well went from 3.2 meters per second to 2.6 meters per second. Look at the pulmonary vein Doppler. The S was smaller than the D, now the S is larger than the D. Okay, so LA pressure has normalized at rest. Maybe if we observe the patient, if we do the diastolic stress echo, the LA pressure may go up, but at rest at least, tremendous difference in 3 years. What happened to this patient? Well, what happened is that, as you can see, there was no change in LV systolic function, LV ejection fraction, no significant change in diastolic parameter. The E prime is the same, but there was tremendous decrease in LV filling pressure and in pulmonary artery pressure. This is the effect of optimization of therapy in this patient, particularly in this patient diuretics. Okay, patient probably was volume overloaded here with treatment with diuretics as well. Some afterload reduction in the left ventricle helps as well to reduce filling pressure, even though diastolic properties are still abnormal. But what we did is we shifted this patient from grade 3 restrictive filling pattern back into an impaired relaxation here. We went not only by 1 grade, we went back by 2 grades. I can assure this patient here is much less symptomatic than in grade 3. And there was reversibility. This patient has much better prognosis than if he stayed here in grade 3. So you can tell here the power of comparison. Now, another patient, 66-year-old male with hypertension. You can see here, there's concentric hypertrophy. Ejection fraction is abnormal. You can see EF is not normal. It was, I think, 45%. And this was in 2020. So let's look at the 2020 parameter. Let's look at you see the mitral Doppler here, the E to A ratio. So there's an impaired relaxation pattern. The E prime velocity is also low. So the E to A ratio is 0.6. E prime and lateral and septal are 5 and 3. So the E prime is 10. So there's a diastolic dysfunction in the setting of systolic dysfunction as well. The EF is abnormal. The EE prime ratio is abnormal. And the E prime is abnormal. The EE prime ratio here is not abnormal. It's normal. I put it in red, but I should not put it in red. But obviously, there's impairment in LV systolic function as well as impaired relaxation. 3 years later, let's look at the ejection fraction. You see, the ejection fraction now is normal. Okay, so let's look at the parameters here. Now, instead of having an impaired relaxation pattern, we have what looks like a normal or pseudo-normal pattern. The question, did we shift left or right? Look at the E prime, the lateral and the septal E prime. The lateral and septal E prime are 9, 8. So the E prime went from 5 to 9 lateral and from 3 to 8 septal. And the E prime ratio even went down. So what happened to this patient? This patient has now better diastolic properties. So there was improvement in LV diastolic function associated with improvement in systolic function. No significant change in LV filling pressure, because filling pressure were both normal at rest. But this is the effect of optimization of therapy, probably with ARNI, mineralocorticoid receptor antagonists, SGLT2 inhibitors, beta blocker, and maybe blood pressure control. But here what happened is we improved ejection fraction. And with improvement of the systolic function, we improved as well the patient diastolic function. So what we did here, we shifted as well to the left. We went from an impaired relaxation pattern to this pattern, which is normal, which is certainly better for this patient.
Is an L wave?
Now,
Is there an L wave, doctor, in the previous slide on the second post-treatment?
but the L wave certainly when it's this low is typically normal. An L wave of 0.1, 0.2 meter per second is perfectly normal.
Okay.
You can see it. You can see an L wave of this velocity typically in normal patient. This is as well part of the kind of sucker left ventricle that really has good diastolic properties, sucking blood into the left ventricle. So yes, a small L wave typically is normal. But look what happened at the E prime. You see the E prime has improved. So you know that the diastolic properties of the left ventricle have improved. Okay, they kind of almost doubled. So this patient went back into a normal pattern from an impaired relaxation pattern. Now, another patient, this is a 28-year-old male with history of kidney transplantation who failed transplantation, went back on dialysis, complaining of dyspnea on exertion. And this is his baseline echo. As you can see, ejection fraction is not too bad, maybe low normal. And let's look at his echo parameters. Now it's a busy slide, but just to show you you can see the IVRT here, you can measure it. You can see E to A ratio looking normal, the S to D ratio in the lungs normal. This is the RA pressure, IVC collapsing. He has a good stroke volume, LVOT. You see the TR velocity is normal. Look at the PR velocity, as I told you, about 1 meter per second, the setting of normal RA pressure, telling us that the PA pressure and the LA pressure are normal. You can see he has good relaxation properties. And so his baseline echo is here, as you saw, and you can tell the left ventricle is dilated. Now, I'm not going to go through details about the LV, but look what happened to ejection fraction. I mean, you can tell the ejection fraction has dropped. Yes, and this is quite obvious here. Now, what caused it is another story, and I'm not going to go into the cause, and it was really published. This was a very interesting case, but you can see what happened now to his velocities, Doppler velocity. You say he went into this restrictive filling pattern. In the pulmonary vein, you can see S smaller than the D. The RA pressure is certainly higher than before. The IVC is not collapsing, but I cannot play it. Stroke volume went down. TVI is 12. TR velocity went up. You see the PR velocity. You see it was, and diastolic velocity was 1. Now it's approaching 2. So certainly his LA pressure and pulmonary artery diastolic pressure went up. Now, and you look at his EE prime ratio. The EE prime ratio on the first echo was 10, and 11 months later, it's 17. So you see the E prime went down from 9 to 6 and 12. This stayed the same at 12, but the septal went down. And typically the septal most of the time goes down more than the lateral. The EE prime ratio of 10 now is 17. So certainly this is abnormal. So you see, you can compare things. You can compare systolic function. You can compare diastolic function. And what happened to this patient, he jumped from normal here to restrictive pattern, even though he's quite young, but he went from normal to a grade 3 restrictive filling pattern, from normal relaxation to impaired relaxation, very impaired relaxation, and from normal LA pressure to very high LA pressure. Now you see, it's very important for us in echo to measure, not to eyeball. And this is a busy slide, but you can tell, if you look at LV and diastolic, volume index. You can see increase in LV volume. You can see decrease in ejection fraction 53 to 33. You can see his stroke volume decreased by half. You can see the LA volume index doubled. You can see the pulmonary artery pressure. The LA pressure went up. You see by IVRT shortened, E velocity went up, deceleration time went down, A duration went down, pulmonary vein Doppler changed from more than 1 to less than 1 for the S to D ratio, EE prime went up. You can see RA pressure went up by IVC. You can see PA pressure doubled. So you can really, I mean, tell that systolic as well as diastolic parameters went down. That's why it's very important to measure, not to eyeball things. And typically in an echo report, you really want to go into details in your report and base your information based on, for example, severely dilated LV. I need to have LV and diastolic volume indexed. I need to have an ejection fraction. I need to have a GLS. I need to know the S prime. I need to know MAPC. Look at filling pressure, and after this talk how to look at filling pressure. Look at stroke volume. Okay, you need to be able to to tell these kind of systolic and diastolic parameters in every patient. And you need to be able to compare what happened since the last study, what happened to your LV volume, to your LV ejection fraction, or other systolic parameter. And as I told you, ejection fraction does not imply systolic function. Systolic function includes as well other things, which is GLS, includes S prime velocity, MAPC, and so on. So they're not equal. So it's really very important to compare. This is from our paper in Chase about spectral Doppler interrogation of the pulmonary vein. If you're interested in looking at left heart pathology, I suggest that take a look at this paper. I mean, I show you here in the paper different pattern in the pulmonary vein that really give you quite a bit of insight into the function of the heart, of the left heart. And it gives you kind of an understanding into many issues. I will stop here. I think I spoke maybe 10 minutes beyond what I was planning to. I showed you maybe, I don't know, a total of 13, 14 cases. I'm not sure anymore, but all these cases are from our own echo lab. I mean, without the help of our sonographers at King Faisal, I would not have been able to show you all these. All these studies were obtained by sonographers. So I want to thank our sonographers for their hard work to kind of allow us to give this kind of presentation. And I thank you for taking time today on a holiday day to listen to this presentation. And I'll take any questions you have. If you have any question, please go ahead, unmute and ask the question.
Assalamu alaikum, sir. I'm Dr. Muhammad Abed. A really nice presentation. Mashallah, you covered everything. Really grateful for that. Very comprehensive, very excellent presentation. I have just one concern. I mean, usually what we are facing while echo reporting, I don't know, maybe we are not with our echo technician during every study, what they are doing. But the data that are coming to us while reporting the echo, sometimes E over E prime is supposedly 0.9. Septal E over E prime is normal, but lateral is abnormal. In that cases where one is normal and other is abnormal, what should we do and how we can report such cases? Okay,
now, I mean, typically the septal E prime is more affected typically in disease more than the lateral. So it seems to be a bit more sensitive than the lateral E prime, and it drops earlier and more so than the lateral E prime. Now the guidelines tells us to average both the septal and the lateral. I mean, obviously, I mean, it's important to look at the EE prime, but the EE prime is one of several parameters. I mean, I suggest to you to look at everything else. I mean, you really need to know about the patient age, as I mentioned. You need to know about the patient's history. you need to look at all other parameters. Obviously, the guidelines tell us to look at the E prime ratio, to look at the TR velocity, to look at the LA volume index. But as I showed you, I mean, you need to look at other parameters. I mean, you need to look at RA pressure to see the IVC, to see the TR velocity, which is normal, underestimating your PA pressure. You need to look at the other parameters I spoke about, pulmonary vein, looking at the S2D ratio, the A reversal, look at the PR velocity, look at the IVRT, look at the M mode of the free wall. I mean, there's so many other parameters, do Valsalva on the patient. I mean, the PR velocity is extremely useful, as I showed you in that patients. So really one has to look at many other parameters. I mean, the guidelines tell us to look at 3 parameters, 1, 2, 3, and that's it. Okay. Beyond the E to A ratio, obviously. E to A will make it 4, but beyond the E to A ratio, I mean, look at 3 parameters. But you really need to look at everything else, because sometimes these 3 parameters, can be normal, or you're not sure, or if you don't have a TR velocity, so you end up having only 2 parameters, and one of them is positive, the other is negative, so you're indeterminate, and there's a lot of indeterminate cases according to the guideline. That's why I showed you. I mean, you have to look at the other parameters I showed you to kind of get an idea about patient LV filling pressure. And if you're not sure, then one thing to do is to do a diastolic stress echo, as I showed you. If your patient has dyspnea on exertion, has exertional symptoms, the diastolic stress echo will be highly useful. Now, even sometimes you do that, and the diastolic stress echo sometimes is intermediate, then the only way to do it is to go to the cath lab and do intracardiac pressure recordings. And those also cannot be final unless you do also an exercise. You do exercise during the patient cath. You document an increase in filling pressure with exercise during cath, which is obviously most cath labs are not equipped to do this. But I mean, I tried in this presentation to show you things beyond the guidelines. I mean, the guidelines are nice and are useful, but I showed you a slide where there are major shortcomings for the guidelines. You should know what the guidelines are, but as well, you should know what the guidelines is not showing you, and you should use those other parameters which I showed you cases about to determine the diastolic function and the filling pressure of your patient.
Thank you, sir. Thanks so much, sir.
Doctor, I have a question.
No.
I'm Dr. Noha from UAE. Sometimes I got a case last week, very confusing. The patient had symptoms of heart failure. When I did an echo, he was in atrial fibrillation, and he had a right-sided dilatation with a severe TR. So I wasn't very sure, is the TR secondary to diastolic dysfunction, or is it because of a primary right-sided pathology? So does diastolic dysfunction cause right-sided dilatation or not?
Oh, yes. I mean, a major cause for right ventricular enlargement and dysfunction is pulmonary hypertension, and patients who have a chronic diastolic dysfunction have pulmonary hypertension. The PA pressure will go up because of restrictive filling to the left heart. So patients with restrictive filling to the left heart and high left atrial pressure typically have pulmonary hypertension, and patients with pulmonary hypertension will have RV pressure overload. The RV with time will dilate, and that will stretch the tricuspid annulus, will stretch the papillary muscles of the tricuspid valve, lead to tricuspid valve regurgitation. So yes, absolutely. I mean, patient with severe LV diastolic dysfunction, restrictive filling, will have pulmonary hypertension, and with time, they will develop RV enlargement, right ventricular failure, and severe tricuspid regurgitation. The problem is when you have severe tricuspid regurgitation and you have a triangular shape signal across the tricuspid valve, you will not able to assess patient's pulmonary pressure.
Yeah.
Exactly.
Yeah, it was the same finding, but I wasn't sure, how can I differentiate it from primary right-sided pathology by echo?
You have to look at what I showed you here. I mean, you have to look at the left-sided.
It was very difficult. It was because it was in fast AF. That's my problem.
Absolutely. Then what you need to do, you need to slow down this patient. And once you slow down the patient, you should repeat the echo and go through the parameters I showed you. Now, there's still a possibility, slowing down the patient and looking at the parameters, you're still not sure what LV filling pressures are. In that case, you would need to take your patient to the cath lab and do a proper assessment, do proper intracardiac pressure recording of the wedge pressure, of the PA pressure, and of the right atrial pressure, and so on. And your patient, if old with AFib and so on, may need at the same time coronary angiography. So if echo cannot solve your questions, then you should proceed to further investigation. And we tend often to not to do much proper hemodynamic assessment for patients in the cath lab, but certainly one should know the shortcomings of Doppler imaging, particularly in difficult cases. For example, your patient with rapid AFib, who you're not sure of the filling pressure on the left side, who has severe TR and so on.
And what's your preferred parameters for AF for diastolic dysfunction other than E to E prime? Will you rely on deceleration time, or what
well,
other things you like?
Well, it depends on your ejection fraction. I'll show you. I'll take you back to the slides I was showing about ejection, about patient.
Yes, because I went to those guidelines and it was really difficult to get the readings, as you mentioned.
Yes, absolutely. I mean, the guidelines are really not good, not very good for this. But certainly, if I were you, the first thing I would do, I would slow down the patient. I mean, bring the heart rate to a reasonable range. I mean, this is really the first thing you should do. Okay, and then go back and do proper assessment of the patient. Let me show you that slide. No, it's not here. So you need to do proper assessment, but in order to do proper assessment for the patient, you really need first to slow the patient down. I mean, give the patient time to slow down and repeat the echo. And look at these parameters. I mean, the E velocity tends to go up, and the deceleration time tends to go down with AFib. So you need to first determine. I mean, does your patient, for example, have normal ejection fraction GLS, or has no abnormal systolic function? That's important to know. 1. 2, does your patient have hypertrophy or not? 3, if the ejection fraction is low, then the deceleration time across the mitral valve is quite reliable in telling you what the filling pressure is. Now, you cannot rely on the TR velocity and the PA pressure, because if you have a severe TR and you have a triangular shaped signal and a large V wave in the right atrium, you'll not be able to use the TR velocity. The left atrial volume will not help you, because your left atrial volume will be increased in your patient. So then you should look at your E prime. You should look at the average E velocity, at the E prime velocity. You can use also the propagation velocity and measure the E to VP ratio. This is something useful. And look at your E prime ratio. Now, if all these still don't give, and as well, what's helpful as well, if the patient has a bit of PR, look at the pulmonary regurgitation velocity, PR velocity. If your PR velocity is high, let's say 1.5 or 2 meters per second, particularly if your RA pressure is high, almost certainly your left atrial pressure is going to be high. So there are many things to look at, but still, if you're still not sure after all this, then you're going to have to take the patient to the cath lab and do proper intracardiac pressure recording.
Thank you so much for the information.
You're welcome. Any other questions?
Dr. Baha, thank you. I think with this we'll conclude.
Okay.
Very excellent and informative presentation. Thank you, Doctor.
Thank you for all of you for being here today. I hope it was useful. I hope it wasn't too confusing, particularly it's a complex topic. So best of luck in your exam. Yalla, bye bye.
Thank you, Dr. Sam.